Dr. Belinda Lennerz is a pediatric endocrinologist. She started her medical education in Germany and eventually migrated to the States, did her pediatric endocrinology fellowship at Boston Children's Hospital, and she, I think, went back to Germany, came back, and since 2015, she's basically been in the States. Hopefully I got the dates right on that. She's, I've already seen her cited 3 times, just to give you an idea of the amount she's contributed to this field. In 2018, she was part of the pediatrics paper that was the most well-cited and cited article in pediatrics in 2018. It was covered in the New York Times. It was the study looking into the type 1 great group. She published another interesting study on type 1 and carbohydrate restriction, and then a really interesting paper on the history of therapeutic carbohydrate restriction. I highly recommend you read them all if you haven't. She is at Harvard, and she is a scientist, she's a clinician, and you know, Dr. Lake did one of these to Eric Westman, so I'm gonna do one of these to her. Dr. Lennerz, so happy to have you here, so honored to have you here, so happy to share the stage with you if you can come up, and thank you so much for being here.
All right, well, thank you so much for the kind introductions, and thank you for having me. I'm beyond excited for this meeting, you know, to have a whole room of people who are interested in low carb and type 1 diabetes. I don't think it's ever happened. And I'm really not here to talk. I'm mostly here to learn from everyone that's here and to share perspectives. So I'm a researcher, and I'm a pediatric endocrinologist at a major academic institution. So that's where my perspective is. But you all have your unique perspectives of, you know, living with type 1 diabetes, raising children with type 1 diabetes, being dietitians, nutritionists, educators. So I think that putting all these pieces together is one thing that I really hope we'll get out of this symposium and this meeting. I put together a very minimal slide deck and then a couple of, tidbits and discussion points. I was asked to hit on a range of seemingly unrelated topics. So what you'll hear from me is my way to try and synthesize the information I have from you into something that can work at a academic institution and in research, because what we can provide in our setting is something structured, something easy to administer. You know, I have probably about 20 minutes to 30 minutes twice a year with my patients. So I need something like a way to start from where they can build on and work with. And I hope I can help you understand your endocrinologist's perspective a little bit too, right? Seems like there's a lot of disconnect sometimes between what a patient expects and what an endocrinologist expects. And some of it comes from maybe not listening to each other, and some of it comes from just a fundamentally different background. So I try to understand both sides, and I will start with what I think some of the major problems are, and then I'll show you some of the tidbits that I was asked to talk about. All right, here goes. Yeah, we're not. So my first slide, I think that both prior speakers talked about glucose in the blood and insulin and glucose in the cells, and how. And I agree with everyone. I think everyone has a different angle of explaining it, but I think we all are on the same page. You can't look at one of the numbers by itself. So the way I understand this as an endocrinologist is blood glucose is like a homeostatic pool, right? So there's glucose in the blood. It comes from somewhere, it goes somewhere. And so in order to optimally control that, we really need to understand where is it coming from, how does it come in, where is it going, and how does it get out, right? And so I think one of the major shortcomings in the field of diabetes, conventional diabetes care and research, is that all the efforts focus on how does the glucose get out, or how, not just glucose, but how do nutrients come out of the blood, right? And that largely hangs on insulin. And we can think about insulin a lot, right? We can use different types of insulins, different doses. We can use different timing of insulin. We can use fancy devices to give insulin in different patterns. And we can use medications that make insulin act better. So those are all great strategies to get the glucose out. But we really have got to also look at how the glucose gets into the bloodstream, right? And I think that's majorly through diet, right? We have the carbohydrate, protein, fat, and that is amino acids, and we've heard about it, sugar, glucose, and then here, like the lipids and glycerol. And so then that needs to be absorbed into the blood and go through to storage. Carbohydrate and part of the amino acids are insulin dependent, so we do need insulin for carbs and we do need insulin for protein. We don't necessarily need insulin for fat if we were just to consume it by itself, I guess. But as we've heard, fat can delay and change how those other nutrients are absorbed, and so we need to take it in consideration as well. And then, so I think that is mostly diet, right? And then there can be ancillary strategies such as exercise, maybe medications that change absorption and those kind of things. But essentially it anchors on those two. And interestingly, even though I just said the field focuses on these two, and we should look more at all those factors, I was asked today to speak a bit about those two, which is a bit paradoxical, but I shall do it. And then tomorrow I'll talk about a lot of the research that others and myself have done in the field of low-carb nutrition for type 1 diabetes, specifically for kids. I'll talk about what research has not been done, and also about what research should be done. But today I'll talk about insulin and technology and how it interacts with diet. So diabetes care strategy, I think most people here know. We need basal insulin because our cells need to be fueled constantly. We don't just need glucose in our cells when we eat. We need a 24/7 steady fuel supply, so we always need some sort of basal insulin level in our blood. And then we need a lot more insulin with meals. And so this is a typical regimen, even given by syringe, by pen, by pump, a basal insulin that can be a one-time shot or a basal rate, and then meal boluses, snack boluses, ideally 3 hours apart, but if it's not 3 hours apart, they may just overlap a little bit. And we have to think about if it overlaps. I think it's not the end of the world, but if it overlaps, so we have to think about how we interpret a blood sugar that we check before the meal. Because usually before a person eats, they give insulin for what they eat, but they also give insulin to, if the blood sugar were to be high, to bring that back into range. So if I eat too closely and I still have insulin and nutrients coming in, then it's a bit harder to understand if I can give more insulin to bring blood sugar down further or not. So that's kind of where the 3 hours came in. So more problems. So one problem with this system, when we give insulin by shot or by pump or whichever way, is that we give it in a different place. Usually the pancreas produces insulin, it goes right in the portal vein, and the liver sees a very high insulin concentration. Insulin passes through the liver, some of it is broken down and metabolized already in that first path, and then it kind of gets distributed to other tissues where it acts on fat, muscle, other organs, right? And so healthy person has a much higher level at the liver, and the liver is a major organ for storing glucose when we're not eating. So when you eat, like, a lot of glucose is shifted into the liver, so we need a lot of insulin to do that. And then later on, that can be brought back out. Here with type 1 diabetes, all the insulin is injected subcutaneously, so I immediately have a very high insulin concentration in the peripheral circulation. By the time it gets to my liver, it's a much smaller dose. Now, that isn't going to work well because I need a lot of insulin on the liver in order to bring everything that I just ate into my liver to be, stored and metabolized. So I need enough insulin at the liver to be able to control that blood sugar, and in order to achieve that, it goes at the cost of exposing other tissues to much higher insulin doses. And so it's not surprising that kids with type 1 diabetes do have higher rates of overweight, obesity, metabolic syndrome, and other metabolic complications, even though type 1 diabetes is an autoimmune condition and not it's not type 2, it's not like a metabolic disorder in the first place, but over time with insulin treatment, kids get more overweight and obese. And also studies show that usually if you don't think about your diet at all, the more you improve glycemic control with giving more insulin, with giving better insulins, with having better protocols to regulate your blood sugars, so the more you accomplish on a blood sugar level, the more overweight and obese do those kids get. So that cannot be the only solution to the problem. The second problem, I think, is the mismatch between insulin action and nutrient absorption. We have lots of different insulin that acts in different ways, but generally speaking, carbs just act a lot faster than insulin, so it's never a perfect match. And even strategies like using more and more rapid-acting insulins and giving the insulin 10, 15, 20, 30. I have families that try and give the insulin 45 minutes before they eat. But even with that, it's impossible to match, right? Because not all carbs are the same. Some are absorbed very quickly, and some are absorbed very slowly, and the whole spectrum in between. So it's very difficult to match insulin action with carbohydrate. And so between those two things, it's challenging. And so I want to talk about some strategies that we can do, like use when as we've heard, a low-carb diet can help mitigate some of the very high doses, some of the mismatch, because nutrients on a low-carb diet, the carbs we eat on a low-carb diet are much slower-acting carbs than the carbs we eat on a high-carb diet. And protein is a much slower, much more stable fuel, as we heard in the other presentation. So, and so that's more conducive to the insulin action profiles for the insulins we have, in addition to needing less insulin and having less of a mismatch. So what I was asked to talk about is here, and then I have discussion materials that we could be either I could go through them or we can go be interactive about it. So. Carbs, protein, fats, I spoke about it a little bit, types of insulin, diluting insulin, pumps, bolus strategies, technology, like CGM. How do I look at a CGM? I don't think we have to talk about that very much after the excellent preface by Ian, but I'll show you a bit more mainstreamish things. And then how can we use pumps and other technology to help with the diabetes management and care. And then lastly, what's your endocrinologist going to look for when you come to the annual checkup? All right, materials for discussion. So I agree that covering for protein is a very individual affair. Like not everyone's the same, and not every protein is the same. Just like not every carb is the same. So I would be hard pressed to come up with a perfect formula to dealing with it. But again, coming from a setting where we do research and where we see patients in limited time, we have to have a starting point. And so the starting point that I have for protein coverage, so we spoke about carb ratios before, right? Like a carb ratio is how much carbohydrate do you give for a certain amount of, how much insulin do you give for a certain amount of carbohydrate? And 1 to 10 is typical for an adult. For a kid, it can range vastly. Like babies that are diagnosed with diabetes could have a carbohydrate ratio of 1 unit for every 350 grams of carbohydrate, and teenagers can have a carbohydrate unit of 1 unit for every 2.5 grams of carbohydrate. So the range is massive depending on age, size, metabolic needs, hormone status, and so forth. And there is empiric ways, to guess what the carb ratio might be for a child with type 1 diabetes, and then it needs to be adjusted quite frequently as they grow and as their health state changes and as things go over time. Same for protein, right? So the way I think about protein is The reason that I think protein changes your blood sugar is because about half of the amino acids that we consume, depending on the type of protein, but say half or a third or 2/3, will be metabolized through glycemic pathways, so gluconeogenesis, and will eventually end up in the bloodstream as sugar, as glucose, and so that needs to be covered with insulin. And so that's why when I kind of think about how do I cover protein, it's like I say, well, maybe 2 to 3 grams protein is probably gonna show up similarly on the blood sugar as 1 gram carbohydrate. Again, with a caveat that that may have to be adjusted, but it's gonna happen a lot more slowly, right? It's not gonna happen within 15 or 30 minutes like the carbs. It's gonna happen over the next 2, 3, 4 hours. So we need to think about the direction, the action of the insulin as well. And so a simple way to put that into practice with patients is just, ask them to estimate the amount of protein that they eat, whichever way they want. You can look it up on the nutrition label. You could have a rule of thumb. You could weigh it. You could probably, most kids eat a pretty limited variety of meals, like, 5, 6, 7 meals over and over again. You could probably just get a sense of how does this meal affect, how does that, but anyways, estimate the amount of protein you're eating, and then kind of divide that by 2 or 3, and then multiply by the carb ratio, and you'll come up, and then add that up. So that kind of is how we try to get at that strategy, and then over time, patients develop their own strategies for sure. The other thing that I do differently when I have a kid on a low-carb diet compared to a standard carb diet is I ask them to count the carbs differently. You may have all heard that when you're on a standard carb diet, you really only count the starchy carbs. Like, you'll count the carbs from bread, pasta, rice, fruits, juices, but you wouldn't necessarily count carbs from cauliflower or lentils, so some of them more, fibrous vegetables that do have carbohydrate and sometimes do need to be taken into consideration with a low-carb approach. Why do people say protein doesn't need to be covered? I've heard that several times today. I think the reason people say that in standard practice is that you get so much insulin with your carbs that the minimal amount of insulin that you would need for the protein that you eat at a meal is not going to make a difference, right? It's going to be just within the margin of error of your insulin dose anyway, so it probably doesn't make sense to even bother if you're going to eat a standard diet that always comes with carbohydrate at meal. It matters then more if some people start to eat low carb, because then technically if you're going to eat a low carb diet and you use the standard endocrine advice to only give insulin for your starchy carbs. Like, who eats starchy carbs, right? Potatoes, rice. So how much insulin would you even give for a meal, right? And I get that. I literally get patients that go on a low carb diet and that they stop taking mealtime insulin because they don't eat the carbs that they're being asked to cover. And I think that's where the misunderstanding and disconnect comes from in part, because if you take a lot of insulin with a meal, you don't need to think about those finesses or nuances. Thinking about different insulins. So in general endocrine practice, you always want faster, faster, faster. The faster insulin is, the better, because it matches better with your normal carbohydrate absorption profile, right? So carbs, absorption, if you eat like a piece of bread or bagel or, potatoes, or absorption peaks at 15 minutes, goes up to 30, and then comes back down. Even the most rapid-acting insulin peaks at about an hour, and then it lasts for a good 3-4 hours. So even the most rapid-acting insulins have a hard time keeping up with the speed of carbohydrate absorption. That's different when you go on a very low-carb diet, right? Like if you're going to think my protein, I just said, absorbs over 2-3 hours, and fibrous vegetables, like those carbs are slow as well. So you kind of want to think maybe having a little bit of a slower acting insulin. in your repertoire for that. And regular insulin is a common one in the low-carb community because it matches fairly well with the rate of glucose appearance from protein. The other ones are more kind of longer acting, and I can answer questions about those if you are interested. It's tricky some people can get away with just using the regular insulin for low carb, but it's not very fast at correcting a high blood sugar. So if you have events of having hyperglycemia, more rapid acting insulin could probably bring down your blood sugar a little bit faster. And so then you're talking having 3 different insulins, right? A long acting, a short acting, and a rapid to manage your hyperglycemia, your meals, and your basal needs. And that's where you're gonna probably get some pushback again from your endocrinologist, because there are studies that show the more different types of insulin you have, the higher the likelihood of getting them confused and making an insulin dose mistake. So that's kind of so much wisdom for that. I was asked to comment on diluting insulin. A lot of people, diluting insulin is a standard practice in pediatrics for small kids especially. And here's the reason. You've all seen an insulin syringe, right? So this is a typical insulin syringe. It's really small. You know how, it looks very big here, but it's really actually a tiny little thing. And this has 100 units of insulin. So if you have, say you have a carb ratio of 10 and you want to eat a meal with 6 grams carbohydrate, so you could give about half a unit of insulin. So here is 10, right? Here is 5. So a half a unit doesn't even come into the body of the syringe, so that's all going to kind of be stuck in your needle. So how are you going to do that, right? Now you can use these ones that are like half unit syringes with only 30 units. So a half unit, you could probably pull up a half a unit that would be right up here. But it's technically very challenging and it's very imprecise, so it's very difficult to do. Now I just told you there are some little kids that have a carb ratio of 350 or 200. You'll never be able to give any insulin to that child, right? They'd have to eat literally 350 grams of carbohydrate to get 1 unit of insulin, and that's just not, so they would never get any insulin. And so we dilute insulin a lot. And the most common dilution is 1 to 10, and the way you would mix that is you put half a unit in 9.5 milliliters of fluid that's used for dilution. It's important that it needs to be compatible. You can't just dilute any insulin with any solution. Each insulin has their solution that's valid, and that kind of doesn't disintegrate the insulin, so you can't just mix it up. I think we try to not do that as much as possible. The reason to not dilute insulin is that it is one of the most common sources of serious medical mistakes. So if you have a child on diluted insulin, and so now you want to give your child 1 unit of insulin, right? It's diluted 1 to 10. So you can draw up 10 units in your syringe, or 10 lines in your syringe, and that'll give 1 unit of insulin. If someone accidentally gave that child an undiluted insulin, which is the major insulin that's around in the medical community and with caregivers and everyone, the child would have a 10-fold insulin overdose, and that could be devastational, right? So we really, really try and be careful with that, but sometimes it needs to be done. And I think what applies to young kids applies to people who eat a very low-carb diet as well. Sometimes when you are on a very low-carb diet, you just need a tiny dose of insulin, and that might be a possibility that you have to do it. But anyone who uses diluted insulin, I think, needs to always be very much on top of it. Tell all their caregivers and doctors, my insulin is diluted. This is diluted insulin. I take diluted insulin. Always just be aware. And it's tricky because the syringe says unit. So if you draw up 10 and you think that's 10 units, it's not 10 units, it's just 1. All right, so that's that. Insulin pumps help us mitigate a lot of those concerns, because with an insulin pump, you can give insulin very precisely. At the insulin, your bolus increment, you can give 0.01 units, or 0.05 units, depending on the insulin type. So the increment is really, really small. So that essentially allows us to do what we do with diluted insulin without having to dilute it. So that's, I think, one of the reasons that the majority of young kids are now using insulin pumps. And you can also use different bolus strategies to make do with a lot of the different types of insulin. So there is the regular bolus in the pump is you just put in the amount of insulin you want to give. Typically, a pump has Humalog or Novolog insulin in it, which is a rapid acting, and it gives you a bolus. That may work well for a standard carb diet. If you want to eat a super high carb meal, you could even do something that's called a super bolus. So you could give the insulin amount for your meal, and you could give whatever you were supposed to get as a basal rate for the next 2 to 3 hours and add that onto your bolus and then suspend for 2 to 3 hours. So that would give you a lot of insulin up front, like very fast bang for your buck, and then just stop the insulin to avoid later hypoglycemia. You can give an extended bolus, and you can give either a square wave, which is a bolus that is given over 2, 3, however many hours you want it. And so that's commonly used for covering a protein, right? Like if you want to cover a protein, you can say, I want my insulin, I think I'm going to be high or rising over the next 2, 3, 4 hours. You can give your bolus over 2 or 3 hours, and that kind of works well together. Or you could give a dual wave, which gives a lot of insulin up front, and or part of the insulin up front quickly, and then the rest slowly over a couple of hours. So I kind of really like some of those strategies to cover different meals and situations without necessarily having to use a lot of different insulins. And then the next cool thing about pumps is pumps can talk to your continuous glucose monitors. And that's really kind of revolutionized the field in a way, because you can get very good glycemic control when you're not eating, right? When you're not eating, people eat. So the major challenge with those systems is to control what you eat. So we haven't really made a lot of progress during the day hours with those systems. But if you had a system like that, where the pump talks with a CGM, and you eat a low-carb diet, that could be really beautiful. The reason those things don't work well for a high-carb diet is because once the pump knows that you're rising, it's just really way too late to go up on the insulin, so they ramp up the insulin way high to try and catch up with it, and by the time this blood sugar turns around, you're already dropping and you have too much insulin on board, so it sends you on this roller coaster. But I think combined with a slow nutrient, this could work really, really well. And we use some of those in our practice. I think some algorithms are better than others, and I'm happy to take questions about that. But one thing that I've heard from the low-carb community that people don't like is that the commercial systems don't let you set a blood sugar target lower than 100 or 110, which is spectacular for most, but unacceptable for quite a few people who want to aim for normal blood sugars. The big hope is the system that was approved a year ago by the FDA, and it's the tide pool loop, and it is kind of derived from some really genius algorithms that people have programmed and put together themselves, and so it's fully customizable. It works really well. You could set whatever target, and it's very promising, but it's still in a stage where it's, I think, hard to get. Like you need to have some sort of a skill while they're working on bringing out the app to be a bit more available. But I think that could be great. Short of having a system that works together, I wanted to comment on basal rates real quickly. So we've heard that insulin needs are different at different times a day, and insulin resistance is different at different times a day. So one thing that we do when we give a long-acting insulin is we achieve a very steady basal insulin level. It's really not that physiologic, because people need, this is a typical insulin requirement profile, people need much more insulin in the early morning hours, and there is a second pike, at least in kids, in the evening hours. So you don't need a steady level of insulin, you need a kind of a modulated profile. And you can do that with a pump, right? So you can really set your pump to give more insulin at times where you think you need more insulin. In Germany, as in the US, the standard of practice is that you just put a fixed rate in it to mimic what your basal insulin would do. In Germany, we did this kind of fancy thing where we kind of programmed an empiric pattern that looked like that. So we tried to give more insulin in the early morning, less insulin during the day, more in the evening. And then we would do something that was called a fasting or a basal profile test. And so in order to do that test, you would just set your basal rates, and then you would have a person fast for like 5-6 hours at a time and look at the trends of your blood sugars during that time. So if you're rising, you need to give more insulin before the rise. If you're dropping, you need to give less insulin before the drop. And then, so you fast, you see how it goes, you adjust, and then you fast again, right? Until you kind of achieve some sort of a basal perfection. I think it's really exciting to do that and wonderful, but sometimes I also wonder about the real life practicality, because every day in life is so different that I think it's good to start with perfection and then have variability on top of perfection, but I've heard the opposite, where people say, why would you want to do this where every day is so different? But CGM trends. So I don't think I need to talk much about CGM trends, but I'll just say what we use here usually. So this is a CGM trend from like a kid on a standard diet that's considered well controlled. But I know we can do better, but you know what you can see here is like the overnight period. So this is like the midnight to midnight, and then blood sugar from 0 to 400. Here is the conventional range, 70 to 180, and the average blood glucose levels. And so this kid is on a loop system on like Omnipod 5, where the CGM talks with a pump, and that gives them a average blood sugar overnight that's right in the middle of the target range that's been programmed. So the system is working really, really well, even though we don't like to see, this variability. And then you see more fluctuations and more variability during the day when they start to eat. And then we've heard, 70% time in range is the target. And the other thing I like to look at is the average and the standard deviation. So this is, 162 on average, 49 standard deviation. Not too bad for like a kid on a standard diet that's kind of active and doing things. This is what we had published from the type 1 grit survey. They had an average of 104 and a standard deviation of 28. So that's what kind of that type 1 grit group was able to achieve with a low-carb diet. So, and by the way, without a closed-loop system. So this is a kid on a closed-loop system. This is just handmade. I always look at the daily profiles. Like I like this overlay because it kind of helps me understand, when do they eat, when are the major excursions, like when do they get high. Like here's a low after a high, so it helps you understand a bit more than the daily average when you can look at each day by itself, like how do highs affect their lows, how do lows affect their highs, and so forth. And then if you can add a device, it kind of gives you an even nicer dashboard, because now you can look at a day of glucose with a day of basal rate, boluses, and carbohydrate intake. So this is where that child entered carbohydrates, right? So they this is overnight, they said they gave carbohydrate, they received a bolus, and despite the bolus, the blood sugar went up and came back down. They ate again while they're still coming down here. It seems like they ate again here. It worked a little bit better, right? Like it didn't come quite as high, but you can see that there is undulations every time they eat. And then I picked out those two curves. So you can see here that this child ate, right, carbs, and they bolused for it. In spite of that, the blood sugar went up high. So either the carb ratio wasn't quite right, or maybe they didn't wait on that long enough, or maybe it was a highly processed meal, or maybe they just kind of mismatched the insulin with the carbs, who knows, right? But they go up high. And then look what happens here. They give, in addition to the carbs, and the carbs, they notice they're going high, and they give another bolus. But that's solidly within the 2-hour window of having eaten, much less than 3 hours. And so it works, but it brings them down too quickly. And I think that's where the 3 hours, right? If they eat again and they bolus again, it's fine. But if you start to correct a blood sugar where your insulin is just starting to act, right? Like this is just starting to work, and you give it on top of it, then they crash. So I see that all the time. And then here, another cool example of what went wrong here is you see that they entered carbs, they gave a bolus, but the blood sugar is actually rising a good half an hour before they entered the carbs. So probably put that in after the meal, right? So these kind of things. So that's what kind of those readouts can help us with understand a little bit, and I think what people use them for. There's other situations. I didn't bring a million pictures, but you can, sometimes you see like, really boluses like very good control, but bolus every 10 minutes or half an hour, and then you're like, oh, something's not right. We need to change the carb ratio. We need to give more insulin up front, stuff like that. So my last thing, medical testing. So what we screen for in the clinic is we screen for celiac disease because celiac disease is associated with type 1 diabetes, and we screen usually within the first 2 years after diagnosis, then again after 5. You could have a practice of screening every year if you wish. It's practice dependent a little bit, but that's kind of, I think, the minimum. On a low-carb diet, though, you can't really do that test because the test for celiac disease is an antibody test that measures your body's reaction to gluten. And in order for that test to work out, you'd have to eat 1 slice of bread for 2 weeks at a minimum to have a valid test result. So if someone is not eating gluten, might as well not test for celiac disease. But I think it's important that families understand that we won't know if the child has celiac disease or not, and that if they ever chose to reintroduce gluten or carbs into the diet, the kid should be tested at that time. We watch the thyroid for Hashimoto's or thyroid autoimmunity because it's also associated with diabetes. I'm not sure that there is a published association that a low-carb diet would change your thyroid status in a systematic way. I've seen, self-report that people, say they feel better or they may have, but I don't think anything published on the topic. Cardiovascular risk, we do annual lipid panels. So clearly those will be affected by a low-carb diet. So it's common to see elevated cholesterol, total and LDL cholesterol on a low-carb diet, but also high HDL and low triglycerides, which may suggest a pattern in your lipids that is not as disadvantageous as the LDL may make it seem. So I think it gets a bit tricky to interpret those studies when you do an annual lipid panel. And what I've seen is that then sometimes patients don't want to have their lipids checked because they worry that the physician is going to make, cause problems or what. I don't think that it excuses us from screening. I think we just need to be more thoughtful about how we think about those test results and consider additional testing that's not in the routine guidelines. You could consider getting like a lipid particle sizes, or you could consider a coronary artery and calcium score. There's other measures that are valid or more informative on a lower carb diet, but I think it requires some thought, right, to do that. We also screen for kidney health and eye exams and stuff, and of course we keep an eye on weight and growth and those kind of things. And I do think patients should, regardless of their diet, should follow up with a dietitian regularly to make sure they're getting the nutrition they need, from a micronutrient as well as macronutrient perspective. And that's all I had to say.
Maybe as we get more people asking questions and you can come up to the mic, we can take some online questions if there are any.
I do have a couple. Thank you, Belinda, for that presentation. Thank you so much, Dr. Lennerz. There was a question asked earlier that I'd like to ask again and see if you have any input about berberine and grass-fed pancreas being beneficial in type 1. They've heard it's okay in type 2.
It's not part of my practice. I don't think I know very much about it.
Thank you. I just wanted to put it out there.
Yeah.
So in regards to is hypertriglyceridemia a contraindication to starting TCR in type 1?
I would say no, because my hope would be that triglycerides would come down with a low-carb diet. I think there is some thoughts, and I'm sure a dietitian or a nutritionist would be better at answering that question. I think we need to probably think about how we, saturated fats, because when we reduce carbohydrate, we inevitably increase fat intake, and sometimes that's very heavy on the saturated side. I don't know if that's, if you would, consider modifying the fat composition of your diet, right? But I don't think it's a contraindication to low carb.
Thank you. There is one more. I'll go ahead and ask that real quick. Thanks, Lester. Oh, that's Lester, sorry. Corey. I'll just read it. It's a little bit long, so just give me a second. In a 6-year-old child with type 1D, what are your best recommendations for the family? She's actually been doing keto since age 2.5. They try to cook low carb, organic, and grass fed, and she's on a pump. Sometimes her pump alarm goes off through the night. Her doctor says they're already tightly controlled. So is there any way to figure out the best basal rate for nighttime to stop the alarms?
Yeah, so that's very, it's difficult to answer that question without knowing the patient and the family and the circumstance. I would, generally speaking, a basal rate, the responsibility of the basal rate is to keep your blood sugar steady. So without eating anything or giving any insulin, the optimal basal rate should keep your blood sugar level. And if it does not, then it may be, adjust accordingly. But
I'd like to come in here with a question real quick. Sorry to scoot in front of you, but we'll get to you. So the new Medtronic, one of the problems, let's give some context. One of the problems with the Medtronic or some of the pumps is that the previous sort of goal would be 130 or 126, and I know there's newer sort of firmwares that allow you to set slightly stricter goals at 100. And do you think that technology will, increase to the point where we can just put people on closed loops and not have to sort of worry about using regular insulin, using fast-acting insulin, using different basal insulin? And then to tie into that, in my practice, when I've taken people who are type 1 and put them on, TCR, what I've noticed is that their basal rates are often woefully underdosed because they were being covered by the carbohydrates they were eating. So can you talk a little bit about both of those topics?
yeah, so I think that the closed loop systems are getting really close to perfection. I think that the limitations to the targets is more of a regulatory question than a possibility question. You could really, in theory, you could make the pump have any target that you wish, but FDA is asking us to keep the targets restricted to a safety goal. So I think with a do-it-yourself technology, what people can program independently, you can already change and set lower targets if you wish. I think you don't need, if you have a pump, the insulin that's in it is a rapid-acting insulin, so that kind of gets rid of the requirement for regular or for basal insulin because you can just modify your insulin pump to give it, as I showed with a super bolus, the delayed bolus. So you can essentially make a pump mimic the action profiles of all the other insulins in your repertoire, which is why it's nice. I think that there is always going to be a need to pre-bolus to tell the pump what you're going to eat, because insulin does need a little time to get where it needs to be from the sub-Q tissue. So if you just wanted to rely on your pump to eat and have it catch up with it, it's always going to lag behind a little bit. So if you can give the pump a fair warning of what you're going to do for food, I think you could get really close within the next couple of years. And then second question was
sorry, it's the basal being woefully underdosed and on the standard sort of diet in the standard endocrinology. Sorry.
Right. Yeah. So I think that's tricky too, right? It's very difficult to know what your basal rate is doing when you're eating frequent meals and when you're eating lots of carbohydrate. Hence, the fasting studies we did in Germany to really see how much basal do you actually need to kind of stay steady. So if you wanted to do that, you could, right? You can get a near perfect basal rate profile and then superimpose your carb ratios on top of that. Short of that, it's really hard to understand how much basal a person needs, especially during the day. It's easier at night when you don't eat for an extended period of time, but during the day, it's just, the other thing too, if you think about it, just how much basal insulin you get, if we think about a 50-50 requirement, half your insulin from basal, half your need from bolus, it's oversimplified, but then, and you're on 30 units of or 24 units of insulin a day. So that's 12 for the basal, so that's a half a unit an hour. That's such a small amount of insulin, even if it's appropriate in comparison to your bolus, that you'll never be able to gauge the effect of a basal rate while someone's also getting boluses. So do you think you either need to do some math and think about the ratios and proportions, or you need to do a fast?
Thank you.
Mm-hmm.
Dr. Tro, I appreciate that your question came first regarding closed loop being the pipe dream for the ultimate control of type 1, because it's, no offense, it's a very first world biased solution with not everybody having insurance, not everybody being able to afford those approaches. And, thinking beyond just this continent, even looking at the world in general, where we need simple solutions to manage type 1. I was going to comment originally just on your comments kind of representing the endocrinologist's perspective on deterring the patient from dilution, those being errors. One, I wanted to just tidy up that a 1:9 would be a 1 part to 9 part to make a 1:10 dilution. So on your slides, so otherwise you'd be off. So there's some mistakes there, sorry to be a nitpick. But my broader question, since this lecture is being recorded and shared publicly, I've worked in a biochem molecular bio lab with micropipettes. You can get a 10 microliter pipette tip. 1 unit of insulin is 10 microliters. So you can pipette that volume, measure that volume. They make HPLC syringes that will inject that volume into an HPLC machine, and you can inject that with a non-insulin syringe. But you can't find a 10 microliter or a 10 unit syringe on the market anywhere. The smallest we have is a 30 unit syringe, which makes it more difficult to dilute, more difficult to accurately dose. So I wonder if there's anybody anywhere with plastic manufacturing knowledge or any ideas on how to pursue a 10 or ideally even a 7 microliter syringe, because that's about the biggest dose that, according to Dr. Bernstein, that any of us should be diluting or injecting for consistent absorption, because that's also an issue. So, having those dilution options available, I'm 220 pounds. I needed to dilute insulin at my initial diagnosis because 1 unit would cover 40 grams of carbohydrates. So I was stuck eating 40 grams of carbohydrates per meal until I got an insulin syringe for juveniles. And with a large bore diameter, you can't accurately dose half of a unit with one of those.
Right.
So we just need better tools for type 1 diabetes. And not everybody can afford insulin pumps, and they also have their own inborn errors and risks. So, thank you.
Hi. Have you also looked into loop.org, where in comparison to the commercial systems?
Yeah, I have a few patients who use it. It's not yet accessible for most. I think you need quite a bit of savvy to do it.
All right. I'm doing that with my son. We've been using it for 4 years, and another solution that was homemade by someone else. It's actually really easy now to do. You just use a script or a bootstrap, and it'll do the entire thing.
Yeah.
Eric Westman, Durham, North Carolina. I learned from Dave Dykman, the son, that his insulin requirements during puberty went from, say, 20 units a day to 100 units a day. Is that common? And is it true for girls and boys? And are there certain times of life where you have this massive change in requirement?
Yeah, so your insulin requirements go up a lot during the growth spurt. So I mean, 100 units is, that's a big. So I think of insulin more in units per kilo per day. And so I guess a small kid might need between 0.3 to 0.5 units per kilo per day. A teenager, 1.5 units per kilo per day. So that would be a tripling of the per kilo dose during puberty. If you then superimpose that they gain a lot of weight, I think that may reflect Dave's experience.
He's also an athlete.
Right.
Now, backup quarterback for a college football team.
Right. So would that arguably maybe not increase your insulin dose, because you would expect that he'd be quite insulin sensitive as an athlete? I don't know.
The other person I've learned a lot from, Dr. Dick Bernstein, type 1, who wrote the book, The Diabetes Solution. I visited him 25 years ago in his office looking over the Mamaroneck Sound. Just a couple of years ago, I went back and he was sitting at the same table, which he uses for his desk, seeing patients. And so if anyone, I would like you to meet him if you've never met him.
I've sat there for a week.
I thought you did. I wanted to be reminded of that. So at that time, did he do what he did when I was there? His every hour, his assistant came in and said, Dr. Bernstein, time to measure your blood sugar. And he measured the finger stick. And if it was 75, there was shot glasses of glucose lined up. He would drink a little glucose to get the level up a little bit. And if it was 95, he'd take a micro unit of insulin to do that, and he did about it every hour. I don't think he got up at night to do it, though. But I might.
Yeah, I didn't follow him around at night.
Yeah, I didn't stay. I wasn't invited to stay overnight. But so my first response 25 years ago is, I need to write a paper.
Right.
So I did. And so we published a case series of pretty phenomenal results. And he's still sitting at that table.
Do you suspect we could send a student to look at some of his, paper-written records and kind of get that digitalized somehow? I think that would be spectacular.
Well, or even just sitting there, that was the first time I learned that an elevated blood glucose might be a marker of infection. So I was sitting in his office and he's doing telemedicine before telemedicine was a thing. And someone said, well, my blood glucose went up a little bit. He said, aha, get a dental Panorex to look for a periodontal or tooth abscess because it's the harbinger of an infection. Subsequently now, as you're showing glucose going up with infection or hospitalizations, there's a certain cell that needs glucose to fight infections. It's called a white blood cell. So actually, you want the blood glucose to go up when you have an infection, not too much, and then the red blood cells need glucose as well. So glucose is conveniently located in the bloodstream where the cells that need it are. How's that for I think you guys are endocrinologists that have it all wrong. I mean, you want it up a little bit when you have an infection. And we also saw during COVID, Dr. Lake had an elevated blood glucose. It's okay. And so if you're listening, you're biohacking, I get people coming in all the time, Dr. Westman, my blood glucose went up when I had an infection.
Yeah.
Good.
Yeah, I mean, if you can look at Mike Aga's work on like blood sugar control in the ICU. So there is lots
Oh,
of
I haven't seen, yeah.
Yeah. So there are several multi-center studies on the topic in the ICU. So there was early studies that showed if you controlled, like, you know, patients in the ICU tend to have hyperglycemia even if they don't have diabetes, and that's associated with mortality and poor wound healing. So there is an effort to give insulin and control it. And so early studies showed that tighter blood glucose control was associated with improved survival and healing, but then when they did more advanced studies to control it even tighter, there was a point where too tight was again associated with higher mortality. So I think they conclude you have to run it a bit supraphysiologically, but not too high. So
There were also some studies where they were pushing glucose into the cells during heart attacks. This was back in the 80s and 90s, and it didn't help. Mm-hmm. Because the heart muscle likes ketones and fatty acids now in the retrospectoscope of the last 20 years. But thanks so much. And I was just waiting for the next question to come.
Sam still reminds him to test hourly. He is still correcting like that. And he told me he invented telemedicine in 1984.
So Dr. Bernstein did legitimately start the home monitoring of blood glucose. His story, getting his wife, a psychiatrist, to buy a machine. In fact, it wasn't fraudulent, but anyway, they were only supposed to be in the ER. But Dr. Bernstein started measuring his own blood glucoses, and then he invented telemedicine, I guess, no. And the internet, too. No, but he has so much information and so much knowledge that has been relegated to the fringe and all that. Fortunately, we have those videos online, but still, you don't get friends at universities by calling your YouTube channel Diabetes University. Okay, that was supposed to be a little funny or ironic. But so at Duke University, you look at his YouTube channel, it says Diabetes University. Who is this guy, right? Mm-hmm. So anyway, Dr. Bernstein's great. Dr. Lennerz. Oh, is it Lennerz or Lennerz? I haven't met you personally.
So Lennerz is the German pronunciation.
Oh, I can't do that.
Lennerz. Anything that comes close.
Anything goes. Thank you.
Thank you, Dr. Westman, and thank you, Dr. Lennerz.